Med's Prior Educational Group. Today we'll be talking about fetal macrosomia. So to give an overview, first we'll be talking about what is fetal macrosomia, talk about the symptoms, who is at risk, the complications, prevention, diagnosis and treatment, the question, and explanation. So what is macrosomia? So this is a medical term for when a fetus is overly large. Any newborn that is born at more than 4,000 grams, that's 8 pounds and 13 ounces, regardless of their gestational age, is said to have fetal macrosomia. There is no universal diagnostic criteria. The average birth weight is usually around 3.3 kilograms, that is 7 pounds. Usually, genetic factors and maternal conditions such as obesity and diabetes can cause fetal macrosomia. And sometimes it's unknown what causes a baby to be larger than average. So what are the symptoms of fetal macrosomia? It can be difficult to detect and diagnose during pregnancies. However, signs and symptoms include a large fundal height. A fundal height is the difference from the top of your uterus to your pubic bone. A larger than expected fundal height could be a sign of fetal macrosomia. Another symptom is excessive amniotic fluid, which is known as polyhydramnios. So the amount of amniotic fluid reflects your baby's urine output, and a larger baby usually produces more urine. Some conditions that cause a baby to be larger might also increase his or her urine output. So who is at risk for fetal macrosomia? The risk associated with fetal macrosomia increase greatly when birth weight is usually more than 9 pounds and 15 ounces. That's 4,500 grams. So who is at risk? People with maternal diabetes. Fetal macrosomia is more likely if you had diabetes before pregnancy, that's pre-gestational diabetes, or if you develop diabetes during pregnancy, that's gestational diabetes. Another is maternal obesity. So fetal macrosomia is more likely if you're obese as well. Next is excessive weight gain during pregnancy. Gaining too much weight during your pregnancy can increase the risk of fetal macrosomia. Next is maternal age. Women older than 35 years of age are more likely to have a baby diagnosed with fetal macrosomia. Usually, pregnancy after 35 years increases the risk of having fetal macrosomia by 20%. Next, we have folks with a history of macrosomia or a previous pregnancy. So the risk of fetal macrosomia increases with each pregnancy. Next, we have paternal age. So if the father is above 35 years of age, that increases the risk by 10%. Having a boy as well increases your risk because male infants typically weigh slightly more than female infants. Most babies weigh more than 9 pounds. Next is an overdue pregnancy. So if your pregnancy continues more than 2 weeks past your due date, your baby is at increased risk of fetal macrosomia. So, to note, fetal macrosomia is more likely to be a result of maternal diabetes, obesity, or weight gain during pregnancy than other causes. So, what are the maternal complications of fetal macrosomia? First, we have labor problems, such as shoulder dystocia. So fetal macrosomia can cause a baby to become wedged in the birth canal, leading to shoulder dystocia, sustained birth injuries, or require the use of a forceps or a vacuum device during delivery. That's an operative vaginal delivery. Sometimes a C-section is needed. Next, we have genital tract lacerations. So during childbirth, fetal macrosomia can cause a baby to injure the birth canal, such as by tearing vaginal tissues and the muscles between the vagina and the anus. That's the perineal muscles. Next, we have bleeding after delivery. So that's postpartum hemorrhage. So fetal macrosomia increases the risk that your uterine muscles won't properly contract after you give birth. That's uterine atony. This can lead to potentially serious bleeding after delivery. Next, we have uterine rupture. So if you have had a prior C-section or a major uterine surgery, fetal macrosomia increases the risk of uterine rupture during labor, a rare but serious complication in which the uterus tears open along the scar line from the C-section or another uterine surgery. An emergency C-section is needed to prevent life-threatening complications. Next, we have newborn and childhood complications of fetal macrosomia. So possible complications of fetal macrosomia for your baby might include lower than normal blood sugar levels. So a baby diagnosed with fetal macrosomia is more likely to be born with a blood sugar level that's lower than normal. It can also increase the risk of childhood diabetes because research suggests that the risk of childhood obesity because research suggests that the risk of childhood obesity increases as birth weight increases. Next, we have metabolic syndrome. So if your baby is diagnosed with fetal macrosomia, he or she is at risk of developing metabolic syndrome during childhood. So metabolic syndrome is a cluster of conditions where we have increased blood pressure, a high blood sugar level, excess body fat around the waist, and abnormal cholesterol levels that occur together, increasing the risk of heart disease, stroke, and diabetes. So next we have prevention. So you might not be able to prevent fetal macrosomia, but you can promote a healthy pregnancy. Research shows that exercising during pregnancy and eating a low glycemic diet can reduce the risk of macrosomia. Example, we can schedule a preconception appointment. So if you're considering pregnancy, talk with your healthcare provider. If you're obese, you might also want to be referred to another healthcare provider, such as a registered dietitian or an obesity specialist who can help you reach a healthy weight before pregnancy. You also want to monitor your weight. So gaining a healthy amount of weight during pregnancy, which is often around 25 to 35 pounds, if you have a normal pre-pregnancy weight, supports your baby growth and development. Women who weigh more when they get pregnant will have lower recommended pregnancy weight. So work with your healthcare provider to determine what is right for you. Next, we want to manage diabetes. So if you have had diabetes before pregnancy, or if you develop gestational diabetes, you want to work with your healthcare provider to manage the condition. Controlling your blood sugar levels is the best way to prevent complications. Next, we want to also be active. Being active is very important in helping your blood sugar, helping your weight. So it's also important to follow your healthcare provider's recommendations for physical activity. Next, we have diagnosis and treatment. So it is usually difficult to diagnose the condition during pregnancy as the exact weight of the baby cannot be determined. However, methods that can provide an estimate of the weight are currently in use. So methods such as ultrasound. So ultrasound is performed by the end of the third trimester to measure the baby's body parts. The size measurements can be used to estimate the baby's weight. Next, we have non-stress tests, which measures the baby's heartbeat as he or she moves. We also have the biophysical profile. So heart rate monitoring and ultrasound are combined to assess the baby's breathing, movements, muscle tone, and the amniotic fluid level. So for treatment, cesarean delivery is usually the main treatment, and the doctor also addresses conditions in the mother such as diabetes. Next, we have come to our Nbme styled question. So this question asks, which of the following is the most appropriate next step in management? So a 32-year-old Gravida 2 Para 1 woman at 38 weeks gestation presents for a routine prenatal visit. Her previous delivery was a spontaneous vaginal delivery of a macrosomic infant weighing 4,200 grams, that is 9 pounds 4 ounces. Her current pregnancy has been uncomplicated and she has gained 12 pounds, 12 kilograms, that's 26.5 pounds since conception. On examination, fundal height measures 40 centimeters. Ultrasound reveals an estimated fetal weight of 4,500 grams. That's 9 pounds 14 ounces. Which of the following is the most appropriate next step in the management? So we have A, elective cesarean section, B, induction of labor, C, serial ultrasound monitoring, D, dietary counseling and weight management, and E, non-stress testing. So what do you think the answer is? So the answer is A, elective cesarean section. So this patient presents with a history of delivering a macrosomic infant and currently as a fetus with an estimated weight of 4,500 grams at 38 weeks gestation. So as we have just reviewed, that macrosomia is defined as a birth weight greater than 4,000 grams, and it poses risks for both the infant and the mother during delivery. So fetal macrosomia increases the risk of shoulder dystocia, birth trauma, and cesarean section delivery. So in this scenario, the most appropriate next step in management aims to mitigate these risks while ensuring optimal fetal and maternal outcomes. So, given the risks of the shoulder dystocia and the birth trauma associated with macrosomnia, the most appropriate next step in management for this patient is elective cesarean section. That's option A. This approach minimizes the risk of complications associated with vaginal delivery of a macrosomic fetus. So option A is a consideration in cases where the estimated fetal weight is significantly large and the risk of vaginal delivery are deemed high. However, in the absence of other complications or clinical findings that mandate immediate delivery, it may not be the first line option. So option B, induction of labor can be considered if there are no contrainductions such as cephalopelvic disproportion. However, induction of labor in cases of fetal macrosomia carries a risk of failed induction and subsequent emergency C-section. Next, we have option C, which is serial ultrasound monitoring. This may provide additional information on fetal growth and amniotic fluid levels, but it does not address the immediate management required at 38 weeks gestation with a macrosomic fetus. Option D, which is dietary counseling and weight management, is important for overall maternal health, but does not directly address the management of fetal macrosomia at this stage of pregnancy. And option E, non-stress testing, is used for assessing fetal well-being and is important in pregnancies where there are concerns about fetal distress, but it does not guide the management of macrosomia. So thank you guys. Hope you have learned something or it helped in your review for study. If you'd like to contact us, you can message on Instagram at med_spire or email educateandinspire101@gmail.com. Thank you and have a great day.